Always a wonderful conference to be here with TRICO. Can I have my slides? So after you've done a wonderful PCI, wonderful imaging, wonderful tower, you'll have to do equally important job of giving adequate therapies. Once you put a good stent, it doesn't mean that that stent is always going to flow. And there are reasons and methods that we have learned so far how it works. One of them, which is important, is how you manage lipids. Can I have the next slide, please? These are my disclaimers. So basically, dyslipidemia, as we know, is a risk factor, one of the most important risk factor, elevated LDL-C, in management in patients with increased CV risk, especially ASCVD. The LDL story is long. I mean, when I'm sure Tejas Bhai entered medical college, people used to say 190 is okay for LDL. And now we are wondering if even 70 is okay or not. Because it's top 3 of the CV risk factors. You look at the Interheart study or whichever risk factor, attributable risk is maximum for dyslipidemia. So treatment goals have been changing, as I was saying. 2019, it started looking at the adequate values, and they found out that in patients who are high risk, the cutoff needs to be much lower, with score more than 10%, the family history of ASCVD with another major risk factor, or even CKD, or patients with diabetes for more than 10 or 20 years, you need to bring it down to 55. And that's the guideline that existed right from 2019. And I'm going to take you through why this is now still going even below, especially even the Indian Association, Lipid Association of India guidelines. We know that intensifying the goals is necessary to optimize lipid levels in patients with ASCVD, because we also have a double jeopardy. We also have lipo-A, which is prevalent not only in our part of the world, but also sub-Saharan Africa, also in Southeast Asians. And there are studies from ENAS which says that even though the American lifestyle is what the Indians who have born and brought up in USA have adopted, we continue to be twice at risk, probably because of genetic predisposition as compared to the Caucasian counterparts. So elevated LPA, and even if you look at the conventional lipid lowering therapy, they fail to achieve the goal of below 70 in 1 in 30 patients. Most of my patients I put on dual therapies even at the first go. But even then, you may not be able to reach the goal of 55, because only 1 in 10 reach that goal with the high dose statins, as we know. So this is the concept which Shapiro et al., which they have sought. Basically, it's the cumulative lipid that you accumulate. Every year, if you were to do your lipid profile and add up it in the totality, the moment you will cross a threshold, some say it as 5,000, some say it's 50,000 in terms of millimoles or milligram percent, the cholesterol years is what will ultimately be responsible. The final lipid burden is what's going to be responsible for first event to occur. So this we know from severe familial hypercholesterolemia, that they encountered this much earlier in the first decade compared to somebody who's living a good, decent lifestyle with lifelong LDL, with excellent genetics and excellent lifestyle changes, may not even get a threshold and may die of some other cause in late 90s or 100. A quarter of century of treating LDL, how low can we go? So if you were to look at the LDL values, we all know it started from the 4S and CARE at 200. Lipid and HPS studies showed it 160. Lower is better, we knew it from IMPROVE-IT. And now we know that IMPROVE-IT also has shown that these levels have to go down. And now we know the lowest is best. We know that from Fourier and Odyssey series. So LDL goal evaluation, as we know, has been going lower from less than 70 in the ESC guidelines in 2011 to now Lipid Association of India talking about less than 50 in very high risk group or extreme high risk group, and less than 30 for extremely high risk category B, or 10 to 15 for what is called as category C. Practically they are saying that your LDLs need to vanish. Now a lot of people say, will this cause dementia? Will this lead to early Alzheimer's? It's known that whatever lipids that you give or treat with does not actually cross blood-brain barrier much. So there is hardly any lipid circulation between the cerebral lipids and the lipids in circulation. Of course, the concerns is what I'm going to address. Hemorrhagic stroke is one thing. Even Professor Brunwald talked about this, that this is only probably one of the signals that there is maybe higher risk of hemorrhagic stroke. We don't know whether this is an incidental finding or actually happens. Cataract, the data is not supporting, and that people had raised concerns about neurocognitive impairment, hypogonadism, hematuria, etc. But look at the benefits that you have. coronary atherosclerosis, plaque regression, and reduction in composites of death, MI, revasc, and unstable angina for whatever lower values you attain. LDL-C less than 70 post-ischemic stroke even has shown that even without raising ICH risk, the neurologists now practice to bring it down below 70. So the risk of hemorrhagic stroke probably is an outlier from some of the trials, and it may be confounded by other risk factors like hypertension or diabetes or pre-existing aneurysms. 1 in 4 more than major CV events, more than 1 in 4 cerebral infarctions, and recurrent cerebral infarction hemorrhage were actually with a target of less than 70 over 5 years plus could be avoided. Then there was no increase in risk of ICH in this trial. As I mentioned, overall cholesterol brain turns around 250 to 300 times slower than the circulation, and hence whatever you lower is not actually being shunted or shifted from cerebrum or your brain. LDL less than 30, how safe it is. Look at the Improve It trial. Improve It was one that actually brought back ezetimibe. The achieved at 1 month median was 56, and patients who had less than 30 at 1 month had 21% lower risk of CV death, major events or stroke compared to those who had LDL more than 70. And this is when actually it's not the PCSK9s or the inclisiran which triggered it to make us go lower. It's this trial, very simple trial, which showed that lower you attain, better are the outcomes. Now then the meta-analysis was published with PCSK9, no increased risk of diabetes, myalgia, neurocognitive cataract or GI. CTT analysis also showed no increased risk of cancer, and there was a plateau in cardiovascular benefit in the Fourier analysis of the lower LDL and lower risk of CV events. So 68% higher in individuals with LDL more than 70 compared to those who actually had LDLs attained less than 20 in Fourier trial. This is also for the odds. If you look, all of them have adjusted trends P very much significant, and the cumulative incidence rates of the outcome were much lower for the lower LDL. All the curves are absolutely in the direction lower the better. So potential future is, well, the LDL-C has evolved now from less than 100 to, we are talking about this chart where if you plot trials on one axis and zero mortality on the other and track it down as to where you get that zero, LDL will come down to 39 for primary prevention. Instances of lower LDL found in nature are lots of many. Neonates who are born with less than 38. Look at the gun hunters and gatherers or aborigines or Adivasi populations in our part of the world. Their medians and means are much lower. So this is a matter of convenience. I often call this with an example of village of thieves. They sit down together and decide, we are being called village thieves all amongst ourselves. We'll decide and find out an average. If average is 5 and you're doing a theft more than 5 times, you're a thief, otherwise you're not. That rule of averages doesn't hold true for cholesterol. And that's why the lower the better cannot come from averages of what is an urbanized overall society. What it comes from is looking at how we exist from the genetic variants, where loss of function attains an LDL less than 15 and there are no major events. Prior ASCVD, hence less than 55, has been proposed way back in 2023 with the recurrent events. Also, we are talking about persistent LDL less than 10. That's how low you can go in this paper published in Circulation by Rodriguez et al. Lowering LDL-C risk of major events are very significantly lowered even by statin trials. 24% of major coronary events, 25% revasc and 16% risk, and 22% lower relative risk reduction across all events for every 1 millimole of reduction in LDL-C. So these are the potential targets. Now this is how it's going to be emerging. I often joke and tell my fellows that once a patient comes with acute MI, next 10 years they'll be given 2 shots of injections and you may not require a primary PCI. One, that will have a good efficacy to dissolve the clot, and second, that will have good efficiency to dissolve the lipid core of that plaque. These are the therapies that are proposed and have different mechanism of action. Evolocumab, elarucumab, we know as PCSK9, and inclisiran is also had been evolved as a silencing RNA targeting PCSK9. That's the next therapy. Bempedoic is already available in our part of the world. Evolocumab may soon come. So will be voluncerin and palacarsen or opasiran and lopetamide, which may come to our therapy areas, which have all different mechanism of action in managing lipids. So from the horse-drawn carriages to steam-powered vehicles, technological innovations have been there, not only in automobile industry, to modern therapies like inclisiran. PCSK9 inhibition by silencing the mRNA is how it specifically works in liver. It mimics the body's process of RNA interference in the cytoplasm. Greater hepatic uptake of the circulation LDL takes place, and there is reduction and clearance by the LDL in the blood levels. So plasma inclisiran levels, they decline within 24 hours, and they are actually not detected beyond 48 hours. And you know that this is to be given over every 6 monthly after the initial shots of every 3 months, first 2 shots at 3 months difference. So basically it all gets and accumulated in liver, where its silencing mechanism versus the monoclonal antibody, if you look, it inhibits the translation in the liver, leading to reduced synthesis of PCSK9. At lesser frequency, you just need to have 2. Some people tout it as the lipid vaccine, and the mediated liver targeting enables the use of lower dosage of inclisiran and reducing the systemic exposure. Compared to the monoclonal antibodies, you need to give it twice, and they need further research in terms of extra hepatic action, because you never know how the PCSK9 may be beneficial in organs beyond liver. If you look at the reduction from the baseline, absolute reduction and relative risk reduction, high intensity of statin plus ezetimibe lowers it by 65%, but PCSK9 along with high intensity in statin or with ezetimibe lowers it by 75% or 85%. And hence, overall, these therapies, once you will have probably something coming in like vaccination that you need to take once like a flu shot, the lipid therapy is going to change drastically in our lifetimes alone. Guidelines are unanimous. 2023 CSI guidelines talk extremely high risk less than 40, very high risk less than 55. Lipid Association had proposed this in 2020, so I believe that Indian CSI guidelines with the Lipid Association 23 guidelines going even further and reducing it to less than 30 may soon adopt the same. Even the ESC talks about LDL-C less than 55 or more than 50% reduction from baseline. This is strike early and strike young. In a patient which is lipid lowering naive, therapy naive, irrespective, you need to start high dose initiation with statins. Combination therapy is class 2B. I'm sure it's going to go up, as here it is on the highest tolerated statins. If you're not attaining 55, you need to add ezetimibe. And that's why most of our patients, because if we are as an Indians at high risk, I usually go up high aggressive along with a dual combination therapy, either with inclisiran or with ezetimibe at least. Both magnitude and duration of LDL exposure will impact. So duration, LDL levels multiplied by years in life or years in chronology is what translates into plaque burden, and that's what leads to risk of MI, which doubles for every 1250 incremental value in terms of mg per years. So every 1 mole, if you look, there is 30% higher risk of MI. So inclisiran, with its administration of 300 milligrams sodium water is diluted, it's stored at room temperature. First dose followed by 3 months, followed by every 6 months subcutaneously over the abdomen. And the greatest advantage, as I said, it's not detectable beyond 2 days. Only twice is what you need to administer. So the benefits for the existing therapy is that on top of the LDL reduction that you attain with the otherwise therapy, you will attain additional 40 to 50% reduction. The various trials, Orion series trials, phase 1, 2 and 3, a lot of data is already published on it. Orion 10 showed effective 52% reduction in LDL at the day 510, which is beyond a year, and this is sustained even at 90 days or 540 days. It achieved the goals of less than 87% at post-baseline visit and 68% in 17 months, and the total mean change from the baseline at 510 was significant more than placebo arm. On Orion 8 series, beyond 6 years of more than 12,000 patients, this is the largest, longest follow-up. Inclisiran showed consistent long-term safety tolerability, no safety signals, no worsening, and good sustained reduction. 68% of patients, they achieved less than 70 and 52% less than 50%. Victorian initiative, where actually this was given ahead of statin, there was more effective in lowering LDL and other atherogenic lipid with greater attainment of reduction of LDL to below 55. Orion 15, 56% reduction with inclisiran 100 milligram, 60% nearly with 200, and there's significant dose-dependent reduction demonstrated with it with 300 milligrams. 18 also looked at lipolitide, the double problem that we have, double jeopardy that we have. It's effective in Asian patients with ASCVD or high-risk ASCVD with 41% reduction in lipolitide, one of the therapies beyond niacin which actually looked. And we all know how niacin died with aim-high study showing increased risk of hemorrhage, hepatotoxicity, and niacin was withdrawn from from our world. Inclisiran gives long efficacy analysis of 7 trials, long-term safe and well tolerated, very few adverse events, no impact on safety even with adverse events, only local issues at the injection site were the probable events that were found out. Orion 9, 10 and 11 meta-analysis, they've looked at again exploratory outcome, offer early insight in potential CV benefits and suggest approach that may benefit in these patients. Predicted change 10 years, 28% reduction in relative risk reduction for absolute reduction of 7% of 5,000 hypothetical Orion-like patients with might have CV events of almost 31,000 over 10 years can be lowered significantly. So extreme high risk group, further lowering is what is recommended. The guidelines are pretty clear now. CSI 23, keep it below 50. ABCD UKKA also includes it as a secondary prevention who failed to achieve goal. ACE trial, ACE guidelines in Singapore, ACC 23, ADA 24, and NICE guideline in 22 all talk about lower goals and have incorporated inclisiran as a therapy of choice. Even CSI guidelines categorizes, as I told you, to bring LDL below 40 in extremely high risk. You have a recurrent event, you need to bring down LDL in these group of patients with recurrent events to below 40. So twice effective, and that's the therapy message I want to give you. These are my disclosures. Thank you very much.